Right, we turn now to emergency preparedness, and I'm going to invite Ian to introduce the paper, please.
Thank you, Chairman. This paper deals with what's called in the jargon EPRR. That unpacked means the ability of the NHS to be prepared for threats to its normal operation. Its resilience, it's the way it deals with those threats, and its response if something significant happens that could disrupt the way the NHS normally works. And it aims to take members of the board through the headline responsibilities, important responsibilities that sit with the commissioning board, and I'll talk about those in a minute, in the new NHS architecture post the 1st of April 2013. It goes on then to talk about a little bit about the design work that's been undertaken, and in particular the role of how we work with other agencies to ensure the NHS is well prepared. And then finally it asks the board's approval for some practical steps as we move from a multi-agency discussion on design through to implementation over the balance of the 12-13 year, so that the new architecture is in place and effective from the 1st of April 2013. So let me just run through those things in roughly that order. So the NHS Commissioning Board has important responsibilities in relation to the emergency preparedness and response capabilities of the NHS across England. The Department of Health guidance summarises these as follows: that the NHS Commissioning Board will be responsible for ensuring that there is a comprehensive NHS emergency planning, resilience and response systems that operates at all levels, for assuring itself that this system is fit for purpose, and importantly for being prepared and capable to, quote, lead the mobilisation of the NHS in the event of an emergency or an incident. So that's significant and puts the onus on us to be able to demonstrate that we have that capability. That requires us to do several things, most notably to get on creating and implementing a strategy for getting us to that place by the 1st of the 4th 2013, and as part of that to put into place a national assurance framework for deployment across the NHS to ensure that that's taking place, including involving a discussion with providers of NHS care who will be part of this system, because they have some responsibilities here as well. We have to ensure that the NHS Commissioning Board has the capability for command and control of the NHS should an emergency demand it, and importantly we have to do that because we can't do all that just on our own. We have to work with other bodies, most notably Public Health England and local authorities through their Directors of Public Health, who have complementary responsibilities to help the NHS be resilient. So just to unpack that a little bit, the things I've just pointed out are captured within the new emergency planning model. That's very recently, the last few working days, been published, having been signed off by the relevant agencies, and that aims to define the core roles at national, regional and local levels in terms of preparedness and response. So starting then with the local level, and you know the cornerstone of response to operational threats is always going to be at the local level. In each of the 39 local resilience fora areas, that's the current arrangements for multi-agency preparedness based on police boundaries. In each of those areas we will be establishing a local health resilience partnership that will bring together, under the co-chair of a representative of the NHS Commissioning Board plus a nominated local director of public health, all the key emergency preparedness leads from local parts of the health system, with the view then to ensuring that the right people are all in the room and can work together to ensure that their system is well prepared and resilient. That model of working, which brings together the key parties, is then replicated at regional and subsequently national levels in relation to the NHS Commissioning Board, and I'll talk a little bit about that in a minute, but also in relation to our partners in Public Health England. So in relation to the Commissioning Board, the responsibilities that come with emergency planning will be built into the NHS Commissioning Board's operational model for its area offices, its regional offices, and for the centre. At each of those there will be staff who are designated to take forward these responsibilities, and at national level it's my responsibility to be the key link through to this board going forward. The paper goes on, I think, and it might well be worth mentioning, to discuss the roles of who leads incident responses, because incidents by their very nature are many different types. So for many incidents, just as the public health leaders currently respond to things like food poisoning incidents, in future local directors of public health supported by Public Health England will continue to take that lead. Our interest in that is obviously to be kept closely informed through the local partnership so we understand what's happening, but to be able to take over the management of that incident if it spreads to a point where it pushes real pressure on the operational capacity of the NHS to deliver its normal services. That requires excellent joint working and the kind of capacities that I've talked about previously. And our job over the next few months, I think, is very much to build on the capacity that already exists out there in the NHS, because existing people are doing this and doing it generally very well, and we need to just align that to the new architecture now. So that's the broad description of the system. To get from where we are now to aligning this to the new architecture by the 1st of April 2013, the paper talks about a number of concrete actions that I feel we now need to take, that I'd like to recommend to you. The first is to, for me to establish on the board's behalf an implementation steering group at national level, which will look over all the aspects of this and ensure delivery within the timescale. It's suggested that the membership of the group will bring together myself and my representatives, the NHS Medical Director, the soon-to-be appointed regional leads of the Commissioning Board, plus, importantly, those staff within the Department of Health NHS leadership team who are currently leading on this, so that we can ensure that there's a proper transition from the current arrangements through to the future arrangements. So that feels an important piece of architecture to get this moving. That needs to be supported by the appointment of leads at national, regional and local level as part of the appointments process, so that as we move through this process we have the people to do the work, and then there's some further work to do on understanding the spend on this and how that deploys across the system. So I think there are a series of actions, some of which I've just highlighted, which need now to be undertaken as very much we move from a design discussion through to implementation over the 11 months. And my proposal would be that the board accepts that those are the right actions to take, and that I undertake to keep the board and its committees updated on progress as we move across the year.
Thank you very much. Comments? No? Bill and then Kieran.
It's clearly an extremely important area of work for us as a board. We've developed in the Board Authority some very good relations with local government nationally over the past couple of months, and this clearly is an area where there's a lot of expertise and continuity in local government. I'm sure they'd be willing to work closely with you on this, Ian, and if it was useful from time to time to invite local authority reps onto the implementation team, I'm sure you'd have an open door for that. Certainly that's been the tenor of discussions we've been having with them.
I'd look forward to that conversation.
Thank you. Kieran.
How do we make sure that the plans are not just good on paper, but that the day we actually need them and we dust them off and they really will work, as opposed to we've planned it, we've thought about it, we've put it on the shelf?
Yes, we need, as part of this process, I think, to look at the testing and exercising regime that goes around this, so that local people can work this together and actually test out the mechanisms and relationships that they put into place. At the local level, there's already a regular exercising programme that helps people work together. We need to build this architecture, build that into this architecture, so that across this year that's worked through, and those discussions, I think, are already underway.
And that's the kind of thing that will come back to this board.
That's the sort of thing that we can keep the board informed about.
I mean, it seems to me this is a really big and important responsibility of the board, and it is one of those that literally is someone else's responsibility on the 31st of March and then becomes ours on the 1st of April. And so from the 1st of April, we need the capacity to be able to mobilise the whole of the NHS. So that sounds like quite a big challenge to us. And obviously, Ian, and what you're suggesting there, I think is the right thing. I think in terms of a suggestion for me is in terms of the current challenges and risks of the programme that we've got. I think we should add this as a specific one to it. I mean, I'm sure it's in there somewhere, but it just needs to be pulled out, I think, because it is such a strategic issue, I think, for us as we go.
Ian, thank you for the report. I think I'll invite the board to approve the recommendations in paragraph 15 of your paper. But also, I think your assurance to us of regular reports and updates to us is absolutely critical. Taking David's last point, this is an immensely large, challenging question for us, for which responsibility shifts overnight, 31st of March next year, and we, as a board, will need to have the assurance that we're fit for purpose from the next day. Thank you very much for the paper and for your work on it.